All opposed, same sign. Roger, good to see you. Good to see you. How you doing?
Very welcome.
Campaign going well?
Yeah, almost done.
Fun stuff. All righty.
Forward to Saturday's results.
3B, well, everybody's looking forward to getting it over with. Let it stop, whatever it is, make it quit hurting. 3B, Internal Revenue Code 501R, Community Needs Assessment. You gonna run this?
Yeah, let me explain to the folks watching on live streaming, and let me explain to you all as board members why this potentially could be confusing and why I'm going to hopefully set it straight so it's not confusing. We have a requirement for community needs, community health and needs assessment. And it just so happens that we've had 3 cars get to the 4-way stop all at the same time. We need a community needs assessment for our IRS code standards. That is required every 3 years. We have to have that, and we do that. And this committee has reviewed that community needs assessment before, and it's good that we do it. We find out what the community needs, and we figure out if JPS is presenting those needs adequately to them. At the same time we're doing that, and that's what you're going to hear today. That's the report you have today, but I don't want you to confuse that with any community needs assessment that is required by the state and the federal government for our 1115 waiver. We also have to have a community needs assessment that presents where we are and what JPS is presenting to the community, and listening to the community for their input, and a justification of our 1115 waiver dollars.
And don't forget the community needs assessment we're working on for the bond cabinet.
Exactly. And that is our third. And our third one is the Blue Ribbon Committee and the community needs assessment conducted by HMA that we're trying to look at so that we know that we, and Cummings, that we have provided for the community what they assess our needs to be. All of those have some type of a slight relationship to each other and that they are communicating with each other, but we at JPS have not gotten so involved by which we would tell somebody, you do this because we are oftentimes hoping that maybe something will spring up new in one of those community needs that we may have missed on the first. So these are all 3 beneficial. I just didn't want you to be confused as to why we had 3. We have some incredible folks from Mary Ann Roth to Scott Rule who give you all, as members of the board, the luxury of not having to attend every one of these meetings. They do. That's part of their day job, and I appreciate them doing it, so they're in coordination with this. We also have a person on our staff that you may not be as familiar with because she deals with a lot of data, but Amanda English does a lot for us, and she is a data gatherer. She is wonderful at taking data out of the sea of data and pulling out information that's hugely helpful for us. So if you want to know how many people in the Northeast attend Brown Trail Clinic and then also are ultimately seen here at in our emergency room, Amanda, give her 20 minutes and she'll have an answer for you. If you all, as a board member, are giving a speech anywhere and you want to know how many connection patients come out of the city of Bedford, we can provide that to you. Amanda is wonderful. So Amanda, would you just there she is, right there.
Hey, Amanda.
Amanda has done a great job for us. She does a lot, and she's done a lot with the data gathering for this. Mr. Chair, if you don't mind, I'm going to turn this over to Amanda Ayers. Amanda is part of the team that we brought in from an outside third-party source. She'll introduce that source to you all, but she's going to present to you all the requirement that we have by the IRS. That's part of her responsibility, and that's what she's assisted us with. You all, as a committee, will vote on this. The other 2, you will not vote on. The other 2, the 1115 waiver, you will be informed, but you won't vote on it. The HMA data for the Blue Ribbon, you will not have to vote on, but you will be informed of as well. So, Amanda, if you want to, we only have people that gather data who are named Amanda, by the way. But Amanda, not to be confused, but yeah, come sit up here where they can even see you closer, and it takes you longer to get away.
Old, we don't hear very well. We don't see very well. So the closer the better.
Absolutely.
So, Amanda, it is all yours. Thank you. And if you would mind, not only an introduction of yourself, but it will probably help because some of our board members may be unfamiliar with the company, and that would be helpful for them.
Absolutely. Well, thank you very much for having me here. I'm very happy to be here. I am Amanda Ayers, and I am from Health Resources in Action, and we are a public health nonprofit consulting company out of Boston. We do planning, implementation plans, community health needs assessments all over the country. So we're very excited to be part of this project, and we had several teams at HRIA that worked on this project. We had our research and evaluation team that did a lot of the data collection and analysis. We have our strategic planning team that did some of the planning and development of the implementation documents that you have in your information packets. So that's a little bit of background on me, and I'm very excited to be here to talk a little bit about this process and answer any questions that you might have. So, this is what our assessment and planning goals were for this project. It was a short-term project. We were looking at about 6 months here. Some of the other plans and assessments that were done took quite a lot longer. So here we are looking at examining the current health status of Tarrant County. We looked at exploring current health priorities and new emerging data about health concerns that are coming about in the county. We looked at identifying community strengths and resources and gaps. That's very important, because when we're talking about identifying needs, we want to also look at what resources you have available in the community to address those needs. And we developed an implementation plan as a way to address the things that were identified. This is just a brief overview of our process. I will not labor on this, just to tell you that we are in the final stages of this process. We are developing and finalizing those, the community health needs assessment, as well as the implementation plan, and you all receive that as part of your information as well. Those plans are being finalized. One of the great things about this process, and we all know how wonderful data and numbers are, but as part of this process, we were also able to engage the community. And we did that in 2 ways. We had focus groups, and we also had interviews, key informant interviews. And these are the populations that we touched when we did that. And we were able to engage about 40 participants in 3 focus groups, and we did 11 interviews. This is wonderful because it allows us to correlate the quantitative and qualitative data when we do this. We're also able to really hear from people what their individual needs and concerns are, and that of their family, their neighbors, and their community. So it's a wonderful component of the process. Now we will talk about our findings. Here you'll see our top 5 leading causes of mortality. And consistently between 2013 and 2015, you'll see heart disease and cancer maintaining their top spots there. One thing that I'd like to highlight for you is the change in accidents being our 5th leading cause of mortality, and the move from accidents to Alzheimer's in both 2014 and 2015. We can attribute this to several things, one of which is our increasing aging population as an indicator of why that's being highlighted here. That also issues and concerns around the aging population came up in our focus groups and interviews, as well as some of the data, and you'll see that as we move forward. I'm going to go over a little bit of the data here. Here we're looking at diabetes and obesity. You'll see the graph on the left is diabetes adult self-report data from the Behavioral Risk Factor Surveillance System. And you'll see here that's the United States listed, as well as Tarrant County. And on the right is obesity self-report data. And you'll see, for some reason, the United States is on the bottom. Tarrant County is the yellow line. So you'll see a decrease there for diabetes as well as obesity on the right. Here we have heart disease, and we have heart disease mortality for, again, the United States, Texas, and Tarrant County, and you'll see a maintenance there from 2013 through 2015. Heart disease, one thing we wanted to highlight here is the difference in the rate for Black residents experiencing a higher rate of heart disease mortality in Tarrant County residents overall. So on the left, you'll see we have rates for the United States, Texas, and Tarrant County, and on the right, you'll see that difference highlighted in the race ethnicity for Black residents here being at 198.9. So here we're highlighting a difference in that race for heart disease specifically.
And Amanda, if you don't mind me interrupting.
Absolutely.
I want to let y'all as board members know that all of this is on the board portal. You can pull it down, you can see it, And then there will be a special edition of it for Dr. Chuck Weber and myself, to actually tell us what those colors really are, since none of us can see them. So there'll be a special note for the colorblind people.
Yeah, we can see them, we just can't.
We just don't.
So
know
if
they're-
you'll notice, I just want to highlight, and I don't know if you can tell from the slides because they're a little bit far away, but for the United States, there's a circle in the middle of the line to try to identify that. So if you can't tell the color, Texas has the square in the middle of the line, and Tarrant County is identified with a triangle.
Yeah, but
So
I
that's-
don't know my shapes.
Okay.
I'm okay, I got
That's, we did, there was an effort made to try to just make some distinction there, but it is small up on the screen. So Tarrant County is the triangle, if you can make that out. Okay, here we have cancer mortality, and again, you'll be seeing on the left, we have cancer mortality with Texas being the blue with a dot in the middle, and then we have the Tarrant County rate. You'll see that there's a decrease here. On the right-hand side, we're looking at cancer mortality by type, and you'll see that we have breast cancer, prostate cancer, cervical, colorectal, and you'll see those rates. It's easier for me to look at that screen over there. Sorry, with the line over there. And you'll see that we have breast cancer, colorectal, cervical is on the bottom, colorectal, prostate's there in the middle. So that's the cancer mortality by type.
Can I ask you a question?
Absolutely.
How does, for this data, how does they determine that it's death by cancer? Is that through a different database or the certificate of death? Because
I believe that's on the certificate of death, but it's also tracked through the database.
through the
So,
database?
yeah.
Because not a lot of people die of cancer, they die of something else.
There are co-mortalities, so yes, there are different things that, you're right, they could be listed as both, but
So is there, do they blend the number in so that we can have a very accurate number? Or is there another segment that we need to add on to look at the data differently?
in terms of comorbidities,
Right, because, like my dad, he had pancreatic cancer, but he died of a heart attack. But truly, he died of pancreatic cancer.
okay, I see what you're saying.
So I'm just trying to get my,
No, it's a good question. It's a good question. And I can actually look and get a clarifying answer for you on that, about how they actually narrowed this down, whether that was from the death certificate or the county data.
Mr. Nguyen, there is from the medical examiner, they're trying to get us away from, I mean, everyone dies of a cardiac arrest, but they don't want you to put that down in the death certificate. They want you to put down what was really caused, yeah. So there's been a change from the death certificates.
so we're looking at closer and
Yeah.
closer results.
Stay away from, yeah.
You don't need to get the other one. You
Okay.
answer my question.
Yeah.
Thank you.
One thing I wanted to note here is that when we were talking to people in focus groups and key informant interviews, they brought up breast cancer, skin cancer, colorectal cancer, prostate cancer, as things that they were concerned about. Some of those aren't necessarily reflected in the data as being the highest mortality rates here, but those are the things people mentioned they were concerned about. We also noted in the broader report where Tarrant County is with screening rates, and they are consistent or higher than Texas for cervical, prostate, and colorectal cancers, but their breast cancer screening rate is consistent with the state of Texas. So that additional information is highlighted in the broader report. Moving here to behavioral health. Behavioral health was a clear priority area through the data as well as through the qualitative data gathering that we did. You'll see here that 19% of United States adults reported having depressive disorder diagnosis in 2015, while we have 18.4% for Tarrant County and 16.1% for the state of Texas. So we have a slightly higher rate for Tarrant County than Texas, but a little bit lower than the nation. If you look over on the right, you'll see a list of addiction statistics by actually a disorder. So we have alcohol use disorder, illicit drug use. One thing we wanted to note here is that the conversation and topics discussions that are coming up in the media don't necessarily reflect the data here. So we all know that there's a lot of talk about opiate use, heroin use. So we wanted to make sure we highlighted here that alcohol use disorder is still much, much higher here than heroin, cocaine, et cetera.
But before,
Yep.
go back. The block, mental health is not talked about in Tarrant County.
That was, yep. That was an interview participant, and I think that I know that some of the participants in our interviews and focus groups felt like there was a certain stigma associated with mental health, and talked about getting to a place where people can feel like they can voice and talk about mental health, and when moving in that direction, people might be able to access services better because they can talk about it, feel comfortable about it, don't feel like there's a stigma associated with that and/or getting help.
Is there a model or an organization in which that stigma is not attached to behavioral health and something that we could replicate?
There are
Because
models.
it's talked about a lot.
It is.
But, I guess it depends on, how your ears get open to the subject more than anything.
Absolutely, I agree. And there are different avenues as well. It's about increasing education. It's about how that's represented, even in terms of services, so people feel like they're accessing help in a positive way, and that's a positive thing. So there are a lot of different avenues to address that, but you bring up a good point,
Yeah,
absolutely.
I just, almost 75% of our police calls in the city of Bedford are mental health related. We talk about it a lot. Sure. And so I'm just wondering if there's a replicable model that's a best practice somewhere out there that county-wide we could take with a collaboration between cities and hospital to try to
Yep.
fix that problem, because it is a problem that must be addressed.
And I think what the group did was take some random quotes from people who participated in the needs assessment. And by the way, I want to say that if anybody in Tarrant County has not met any of our need assessment team, I apologize for the three of you that we did not talk to in Tarrant County. We are trying hard to talk to everybody. But I think what this refers to a lot is still that stigma on behavioral health, that if you have a surgery, you'll show somebody your scar. If you or your son or your daughter or your wife has a mental disability or a challenge on behavioral or psychiatric needs, it is sort of not discussed. And I think that's really what that relates to, is that stigma of openly talking about psychiatric and behavioral services.
And another thing I'd like to say from the perspective of doing this work all over the country, this is not atypical to any other county, city, state that we work in. So this is an issue that's being talked about countrywide. There are evidence-based practices to address the issue in different ways, whether you're doing it from an advocacy perspective or increasing education and awareness, lobbying your legislators. There are a lot of different evidence-based strategies to do so, but this is absolutely not atypical. This is happening all over the country.
Well, okay. What really caught my attention is because, yes, there is that stigma we don't want to talk about, but I would submit to you, in the Afro-American community, is the one thing we have been taught in our families and our churches to not discuss. Mm-hmm. We've not felt that there's a mental health problem. I think we're becoming more and more today realizing that. And especially from the faith community and the African American community, you don't discuss that as mental health. Because there's always that solution, go to the preacher who prays for you and go, And so I think it's just far greater than what we are admitting. And that's,
Yeah, good point, good point.
That's excellent. No, thank you for sharing that. Okay, here we're going to talk a little bit about infant mortality by race and ethnicity. And we see here that we have a higher percentage of infant mortality in the Black population here. One of the things you'll notice, the quote on the top is talking about the rate of trauma and that not being addressed. Again, this is also a tie back to the previous slide of behavioral health. So this is an issue, infant mortality is an issue that is high on the radar here. It is actively being addressed. We need to show additional progress in this area. Absolutely, and you'll notice that when we get to the implementation strategies, that has been flagged as something that needs to be addressed. Population growth, projected population growth. Let's see if we, there we go. So here we are talking about where are we going for Tarrant County with our population, and you'll see that the overall Tarrant County population is projected to increase by nearly 40% by 2030, with a specific increase in the aging population. So that has us focusing on the aging population, their needs, things that came up for that population, not only in the data, but also in our focus groups and interviews. We're talking a lot about the social determinants of health as it relates to our aging population. So things that may not have been issues prior to reaching 65 or older are now becoming issues, whether that's housing or transportation, getting access to healthy foods. Due to a lack of transportation, some of those things are becoming issues. So we're looking at a focus there, as well as we noted before, the increase in Alzheimer's disease, and looking at some of those things also that are affecting our aging population disproportionately. And this is just a little bit more information about what I was just saying, our social determinants of health. Chosen to have a clear focus on that in this assessment. So we're looking at poverty, housing, transportation, and food access. And what does that mean? And this is really looking at health in that broader, holistic way to say that we have definitive numbers about disease and how that affects us, but we also want to look at the determinants that lead to the disease rates that we have in the presentation. So for poverty, nearly 1 in 5 Fort Worth residents living below the 100% poverty level. There was a lot of talk in the focus groups and interviews about housing and the difficulty in finding, accessing low-income housing. A lot of talk and discussion about the proportion of people's pay that they spend on housing. And when they're spending that portion of their income on housing, it leaves less for them to spend on medications, healthy food. So you might say to someone, well, why aren't you picking up your medications? Well, if I've spent this much on my rent and this much on other things, I don't have the money left over for medications. It's not that I don't think they're important. It's that when I'm choosing how to distribute my income, that's what's falling by the wayside. So that provides a broader picture as to why some of the behaviors that came out of what people are saying, why that's happening. Transportation, noting that in Fort Worth there's transportation, but looking at the broader county and how we might be able to realize that transportation issues are significant for some of our population in terms of accessing services, and then food access. And we looked at the proportion of and the rate of increase for fast food restaurants and convenience stores versus the rate of increase of grocery stores that might have fresh fruits and vegetables in proportion to the population. So clearly we have an increase in the fast food and the convenience stores and not as much of the grocery stores with the access to fresh fruits and vegetables. So that provides us with a broader healthy food access issue that we noted in the report. This is really important. We looked at community strengths. So, and this was across the board. There are so many wonderful, wonderful things happening here. Starting off with your healthcare resources, a breadth of resources from specialists to trauma care available here in many different avenues, in many different settings. Most people mentioned that. Also cannot mention enough the generosity and the collaboration of the community. People said people are very generous. They will collaborate. There's a willingness to do that, so and an acceptance to do that. And I think that makes people feel really good about the deficits that are happening in terms of maybe food access, that they know that people will come to the plate. We're going to put our heads together. People are willing to collaborate and work on those issues. Support of elected officials. Very, very important. People feel like there's support here and that there's a level of knowledge of the health issues of the county, the importance of those health issues, a knowledge of the social determinants of health, which is huge. So that was really a big community strength. And obviously the resiliency of the population. They say that while people may be struggling, that people are unbelievably resilient, and that's contagious, really, in the population as a whole. And then you'll see some quotes there on the right from some of our participants who were talking about the wonderful strengths of the community. So this leads us to our key community health needs assessment findings. So we have 3 areas of need. The first area is health conditions and service lines. There you're looking at those primary conditions that we've really just highlighted. We have diabetes and obesity, heart disease and stroke, cancer, behavioral health, maternal and child health, and aging adults. Our second area need is information and coordination, and that's looking at access to healthcare, navigation of the system, lack of awareness of services, and care coordination. And our third area of need is the social determinants of health. So really just even more than is happening already, looking at incorporating those social determinants of health into the evidence-based strategies and the programs that we employ to try to address the areas of need in the first and second bucket. And that's all from me. I'm going to turn
Yeah,
it
you're going
over
to we're going to have Wayne come up and sort of give you, just since they're, again, all converging, a little bit of an idea of the DSRIP alignment so that we didn't miss this opportunity while you had y'all thinking in these terms. Mr. Young.
Great, thank you, sir. And we'll probably have a little more detailed conversation about some of the potential changes with the waiver as frankly as CMS and HHSC get a little more clarity to it. But they are beginning to talk about morphing slightly away from a project focus and more into a measure bundle focus. So giving some quality measures and saying, you know, pick which ones you're going to go after and let's go move the needle on these measures. What is up here, this seems to still be changing almost on a daily basis, but these are the measure bundles, the draft proposed measure bundles that are out there existing. That's what all of these boxes represent associated with the waiver looking forward. Those that have the highlighted color in them, it doesn't matter what color, since some people don't see it that way, but those that have a highlighted color to them are the ones that align with the needs that were just identified in that last slide. So where they talked about the service line areas in particular, those are the ones that are highlighted there and represent the overlap between what the identified community health needs are as well as the district potential areas of focus. And I think Mr. Early mentioned earlier, there is a second phase to this where we're looking at some of those needs in the broader regional perspective that will come back for your review and
So Wayne, that's a pretty big change to go from project-based measurements where we've always established these DSRIP parameters into measured bundles. I mean, that's going to change the way we submit, that's going to change the way we measure, it's going to change the whole world when it comes to DSRIP, right?
It has some potential impacts. The one thing that I think might be a little bit helpful is that all of those projects have always had outcome measures attached to them. And so we have been very focused on trying to ensure that we impact that measurable quality piece. And many of those measures that are being considered, potential measures that are within the measure bundles, are very similar or almost identical to many of the measures that we've already been trying to hit. So it's not like it's a complete shift, although it will have some impact on the way we want to go about doing this and the way our approach to this. And I think we probably would have already had some conversations along those lines if HHSC and CMS had a bit more clarity to where they were going. It's still a little bit draftish, if you will. And so, but yes, it is probably a natural step forward as opposed to a changing gears completely and moving differently. It's kind of a progression rather than a switch, but it'll certainly have some impact on our thinking going forward. And then the second slide is just a highlight. So, and in your material, there are some charts that talk about kind of a way forward and some of those measurements that'll be a focus interest. But really, future programming of ours related to these needs are going to be developed and informed through the 1115 waiver protocols. Through the ongoing budget process, there's obviously a great deal of input from you into what that priority areas are and how you want to focus our efforts through that budgeting process and impact that you have there, as well as the destination metric reviews. You know, as you've set those destination metrics, they set the vision and direction for our organization as a whole, and then also the KPI discussion. So those kind of annual measures that we're focused on as an organization trying to move forward. All of those things ultimately begin to morph into your direction and impact on the health needs and how we go about approaching those and trying to address those throughout our more operational aspects of this.
I think for those of us who've been around here a long time, it's kind of refreshing to see that those destination metrics still align very well with these community needs. And every time we have another assessment, whether it's HMA or whether it's IRS, they go back to those metrics, and that alignment is still very, very close. So it's good.
There was a great deal of participation, particularly when it came to some of the specific service line needs that were identified by my colleagues who are here in case there are any questions about specific issues, infant mortality or, whatever the issues might be. They're represented kind of broadly by the group that's behind me, so if you have questions about those specific areas,
So
they're
does the
available.
committee have any questions for either Amanda or Wayne? Ralph?
Just one, not so much a question, maybe just a comment, that when you talk about the possibility of redoing as we do district, and how we bundle it. I think that, and I might be wrong in this, but I know we really focused on preventive care when they arrive. And I just think that somewhere, as we look at our mission and the destination metrics, is that we might have to step outside and look at and address before they would get here. I can't give you the full blueprint or plan, but I just think that how we mesh the two, I think we need to start looking at how we do that. So from infant mortality to mental health to diabetes, what is it we can be done? As an example, and I know I'm a person who sits in one of those spots of the captive audience I have on a Sunday, and during the week. So what I need to maybe see where I can expand my role to help with that. But I just think that's is needed.
Yeah, I think you're going to be pleased and see that when we go through the details of what HMA and some of the things, when we start looking at facility planning and where JPS is in the future, looking at that preventative care model and looking what we do for the enhancement for clinics, but also what's offered in those clinics and what we do. I think you'll see a lot of that there, and I think that'll be good.
And Robert, the only thing I would say is that, we use words like district and 1115 waiver, and they sound like numbers, but there's a substantial amount of employees in this district that were brought in for specific projects with those metrics that you talked about, Trent, that are here every day doing the mission. And what happens in Washington and Austin, there's a lot of changing going on, but the needs of those individuals are still here. So, I mean,
Right.
we get caught up in numbers sometime, and there's a lot of employees supporting the mission behind those fundings of those district projects. So, anyway.
Roger. We do this community health needs assessment every 3 years, right?
Yes, sir.
Have we ever taken the previous year's data? Are any of these needs changing? Are we actually accomplishing any of these goals? I mean, does a broader conversation need to be had about, transportation's always been a problem. I'm assuming access to healthy food has always been a problem. How do we attack those problems? And obviously it's something the hospital district can't do, but it seems like if we take, 10 years of these findings and we put them together and the same 10 things are on the findings,
Right.
we have a problem.
Well, I think it speaks to the collaboration amongst health organizations, and I think it speaks to the collaboration among cities and our county. I can tell you that since we've done the study of 3 years ago, the collaboration between us and the county has significantly improved. The collaboration between us and fellow healthcare delivery systems has improved significantly, and we can cite examples of that.
I mean, have we put their community health needs assessments with ours to see how they
No,
compare?
because I haven't seen their community health needs assessments, because we don't really have a roundtable by which those are shared. But Amanda, I know with her relationships that she has with the others, she's an employee of another organization and she has great relationships there. It's been helpful for us to sort of begin to talk. Now, I do know, and Amanda, I don't mean to speak out of turn, Amanda English, I don't mean to speak out of turn. You all, as a group that do gather this information, do have a dialogue amongst yourselves. But I do think there could be, to your point, Mr. Fisher, a higher level by which we do comparables and comparisons.
Yeah, I mean, I'm ready to check some of these things off the list for once and for all.
Sure.
And put the next thing on there.
Yes, sir.
I'm just curious if we have outlier data, do they have outlier data?
We have been, infant mortality,
Yeah.
that has been one that we have been working on, but those numbers are going in the wrong direction. And so that's one that is not something that we need to have something happen before they get to the hospital. So that's that broader collaboration that has to go on. And so I want us to focus on one, so that will get down. That's a critical one for me.
Yeah, Dorothy and I were talking earlier, and I agree. I mean, Ralph, you're recognized nationally for what you've done for the work on infant mortality. But I dare say going back 10 years, I'm embarrassed to tell you, I served on committees way back, community things, and we've talked about infant mortality in this town, in this county for years. Like I say, I'm embarrassed to sit here and tell you, I remember serving on them, and like you say, Dorothy, the numbers continue to go up. It's not all handled at the hospital level. There is a lot of support missing in those communities, and I'm not going to speak for Ralph, because like I say, he's recognized for his work in infant mortality, but I agree with you, Roger, there may just have to be a rifle approach on a couple of these, for the lack of a better term, that we zero in on a couple of them, and because they are the same ones that continue. But now we're back to those collaboration issues. We need a whole lot of other community support. And Ralph, I would hope you would agree that we need more than just after it gets to the hospital. Yeah.
Can I make a, to piggyback on this one, and I guess you guys may have heard it from me many, many times before, but I'm going to repeat it again. You cannot impact infant mortality until you split between, what's clinical and what is, you have to separate victim of crime and other aspects of it, because the number may go down, but the economy goes bad, and you have, hardship. That number may not be sick, but it may be something else. And how do we bridge that gap? And then I'm a little bit confused here on the community needs. I know that it's important to see the community needs, but for us to do proper planning, what is JPS community needs with our own people? Because when you blend it with people from the South Lake area and some other Keller area and all that area, and then when you look at ours, we have inmates, we have homeless, and we have undocumented people. That community needs, our number may jump up, and we don't have, we may be underplan in some area, and we may overplan in some other area. Because I know compliance and all that stuff, you have to see certain number, but you got to see what is truly is our population. Otherwise, we'll miss the whole thing.
There's just one comment, just two quick things. One, Charlie's right on his comments. I totally agree with that. Let me throw two case in points. One is when you look at it, almost like it's bigger than where we are. And if I look at infant mortality just for a second, yes, it takes a lot of collaboration. It's going to take a lot. Now, I would say this because I'm out there with it. One of the leaders in the county addressing infant mortality is this department, JPS. It is one of the key groups out there addressing it now. We do need, Robert, and I know Robert's in full agreement that we do need to look at and get a lead that deals with it in the community. I'm gonna give you here's where the problem. In East Fort Worth, they built the first so-called shopping plaza. It's not a shopping center. So they got his first really full bona fide grocery store in over 30 years, okay? But guess what else they put in that shopping plaza? Every fast food place you can name. If you name a fast food, it's there. Okay, so then we talk about infant mortality. So one is counteracting the other, but there's a, come by and visit me sometime, there's a sermon series I'm doing at my church now, and I've been in it for a month, that the mental determines the medical.
The mental determines the
Mental
medical.
determines your medical. And that is really in the community, that's what it is. So, but I think that,
I'm gonna correct him. The fast food doesn't apply to infant mortality because they 0 to 1, they're baby food. But, but reality is we're doing a great job. I know we got some report about, we break down between term, because term baby you can't do anything about, but any birth before 37 weeks, it had carry a high risk, and it could be medical condition, it could be convenient of the medical staff, or something with before that 37. But on top of that, I think we're doing a great job. I saw a report a few years back that we continue to improve a lot on the clinical side. But when the number that we presented here, it doesn't go down. It's socioeconomic, and how do we break that apart? Because at some point, you beat up on the clinical staff, and at some point, you can't change more than when, I mean, other stuff that can affect that. But how do we show it so that we can get other community leaders, if we can do a community assessment, to participate and to do other things with us, right? Because you're dealing with minority population in essence, you deal with children, teenage pregnancy, you deal with teenage kid having kids that come from abusive family, no support, none of that stuff. And that can affect a lot on that side of it. And it may end up to be SID, but it's not SID.
Right.
But how do we get across that? Because I've been trying to push this since my appointment in 2011, and we're still using the standard number. And it may very well be an adjusted number on JPS so that we can see that we're making progress. Or if nobody think I'm crazy, then
No,
I'll
you're
stop
not.
by.
You're not crazy, but what I do know is that a lot of the babies that are involved in infant mortality is not born at JPS. That is one of the reasons I say that getting other providers throughout Tarrant County so we can see what's going on, find out, and deal with that. JPS is doing a great job, but we have to bring in others to help with that, because it is broader than just what we are doing.
Dorothy, I think your point's well made. Perception's reality. Like you just said, maybe community-wide, they think when you hear the word infant mortality, it just gets attached to JPS. That may not be, nor do I believe that is the case. And based upon what you just said, I think some additional behind them that we've all taken statistics, maybe we need to drill down, like you say, Dorothy, and look. So again, we're not saying it's not a community issue, but I think when you hear the word infant mortality, it tends to get placed at our doorsteps as opposed to some of the other, like you said, Dorothy. So anyway,
We all, I mean, every single one of us serve on committees that go beyond the walls of JPS. And so it's an issue that we all share on a number of different levels. I do think there's things that JPS has done in the last decade that has moved the dial, though, as it relates to those preventative measures, our efforts on population health, the new clinics that have integrated population health as a format and a baseline for care, the access improvement. I mean, I think the numbers that JPS can boast are serious numbers. And I think we have done some amazing things at JPS, but it just goes to show that these needs go well beyond our walls.
Right.
We're gonna have to stay diligent and continue to look at our metrics in every possible way and move the dial.
What scared me is this, when we look at all those numbers and we don't do a good job of stratification, like for instance, growing population, do they have 2 chronic conditions, 3 chronic, 4 chronic, and how risky they move, then we may, for the coordination of care, we may replace that with more people. Instead of using data to drive those, then we're taking money away from treating patients, and we just line ourselves up with a lot more people. And so I don't know what's the formula, that's for the management to do, but I think we need to start planning on those, and then maybe sometime in the very near future, do a DNA test so that we can see marker on that to see if they potentially will have this disease or that disease, so that
That's got a
we
lot
can
of
plan.
implications.
I'm sorry?
That's got a lot of implications.
Yes, but it's usually going, I mean, when you start seeing people volunteer to do that on the side with their own money out of their insurance, it's moving that way anyway.
Well, I think it is. Okay, well, in the interest of something that we could be here talking about tomorrow and still not exhaust the supply of discussion, are there any other questions specifically for Wayne or Amanda? If not, Amanda, thank you for being here. We
Thank you for
appreciate
having
it.
me.
Thank you for the diligence. It's refreshing to see that the numbers that you're producing are very consistent with the numbers that we've been seeing on a lot of different levels when it comes to community assessment. So we welcome you. We're glad to hear this. Anything we can do to continue to support you in your efforts, we want to do. And we certainly appreciate you being here. And Wayne, as always, thank you for your efforts and for the report.
So the last part of her slide was the implementation. When do we hear that?
I'll let Amanda answer that. Implementation steps specific to your alignment needs.
Yes, so that was included in the information that you were given. So what we've done is we've developed one-page kind of easy-to-read tables that do a statement of need, what the need is in the community, what your assets in the community are already, and then some specific strategies to address that need. And there's a table for each of the identified areas.
And I think that, Scott, that table's on the portal, isn't it?
That's correct.
It is. It is.
Good. Fantastic. All right, thank you very much.
Thank
This
you.
is an action item, committee, so we do need a motion to approve this. A motion from Dr. Weber, second from Mr. Powell. Any question or discussion? All in favor, say aye. All opposed, same sign. That motion carries. Thank you very much. Good report. So this will take us to our item 3C, approved contract for project budget for Northeast Medical Home Construction. Roger, I waved the flag for both of us last week when we weren't here, when we finally have been able to say this thing is moving and underway. And Angie Morgan is not here today, but Lou Manningly is. So Lou, if you will come up, welcome. We're glad to have you here, and we'll let you present this item for us. And you've got a couple of them, I think, today, don't you?
Yes, sir. I do. Thank you. Our first item is the Northeast Medical Home. We're requesting for the approval of a contract in the amount of $8,559,112 for key construction. And in talking about the community health assessment, we're excited to be able to take our services out to that area, Tarrant County, to hopefully move that ticker a little bit quicker in the right direction.
We welcome it, and we're happy to have it, and we have been waiting a long time for it, so we appreciate it. Any questions for Lou on this item? If not, then we need a motion to approve. Motion from Dr. Weber, second from DT. Any questions? Actually, would you yield the motion to
Absolutely.
Roger? Because he wasn't able to be here when this thing actually came up,
Yeah.
and I'd like to reserve for him
He can have it.
that motion, and Roger.
Now, if you don't want it, please say, because now we got problems. Go ahead, Mr. Chairman.
All right, good.
So say you made this move.
I'm you
Like
to,
Mr. Motion.
I lived that, but you the appointee, so I.
Well, no, I got to make the motion when we approved it, so get it moving. So let the record reflect Mr. Fisher's motion and Mr. Wynn's second. All in favor, say aye.
Aye.
All opposed, same sign. Thank you, Lou. And you're going to bring us to the contract for trauma advanced practice nurse suite construction, right?
Yes, sir, and that brings us a little bit closer to home to our main campus. We're requesting the approval of the construction contract award to Hutcherson Construction in the amount of $338,500 for this project.
All right, Lisa, can you back up? Do you have any questions? If not, we need a motion.
Move approval.
Motion from Dorothy, second from Dr. Weber. Any questions or discussion? All in favor, say aye.
Aye.
All opposed, same sign. That motion carries. And that will take us to committee reports, and we have our design and construction project. And Lou, you're going to handle that for us too, right?
Yes, sir. Thank you all again. In our design meetings continue for our ED expansion into the shell space and in the Pavilion East expansion. We also have a conglomerate of radiology equipment construction projects in which design meetings continue for our MRI, and we have completed and received bids for our RACS West room and Fluoro rooms 3 and 4, and we would bring those contracts before the board as required. We just approved the construction contracts for the Northeast Medical Home and our trauma advanced practice services. And then as far as in-progress projects, we have our TSP Phase 3 patient room project, which is an improvement of patient safety, in which we have our materials ordered and are waiting for those to arrive for install. as well as our Tower 9 refresh project, in which we're re-licensing that floor so that we can start putting some patients up there. It's coming along great, looks fabulous, excited to open up that floor to everybody. And we currently have the state inspection scheduled the week of May 22nd. So
Projected opening and ready to go is what?
the inspection will be the week of May 22nd, so if they have any items that we need to correct, I would think that week, and then the week after, a week or two after that. Yes, sir.
And let me make note to not only thank construction, but Wanda and Bill and you as a board, because what we're doing is everything possible we can to open up beds for our patients. And that is not easy, and it's not easy in a world where that's just not available, that we can go write a check next weekend and do this. But I want to thank you as board members and thank the members of the administrative team that have worked tirelessly to open up more rooms for our patients, because I think we're really doing the right thing, and I'm proud of them.
Great job. We appreciate that very much. Okay, any questions then for Lou? I don't believe this requires a motion. This is just a report. So with that being said, I do not believe we have an executive session today, right?
I just have one question that is finished, that I noticed that we have not been doing, and I don't know if there was just a decision internal, the score sheet on how we rank when the bid was awarded for construction. Like there was no score sheet on the Northeast for those different contractors.
Yes, we had our evaluation committee as always, and performed our score sheet, and we're bringing forward the contractor that to be awarded that the evaluation committee is recommending award to.
I guess the question that Pastor Emerson has, which is a good one, should we include that information? Because we had historically
It's covered on page 32.
included, and I thought it was in there.
Page 32, Ralph, I think they presented it in a little bit different format than we've seen it. Is that?
Yeah, I'm looking at that now.
Mm-hmm. I think the bid comparison sheet was provided, but as far as the best value selection criteria, we can include that. But it was not
Just
included
want to
in.
look at that. Okay. If that's okay. Sure.
You bet, and we'll make sure.
That's what he's talking about.
Okay, that's fine.
All right, any other questions for Lou? Okay, Lou, thank you. Appreciate it. Good to have you here. We appreciate hearing from you. And tell Angie we missed her, but you did a great job filling it.
All right. Thank you.
All right, no other information before the board, then we will stand adjourned on a motion and vote. Have a motion to adjourn. Charlie, second from second.
All right, separate, whatever.
Dorothy did.